Exclusive membership with Abode of Opportunities, where we believe in a world where knowledge drives progress in oncology. Let's shape the future of cancer care together. Cancer-related cases are rising significantly, with increasing complexity in diagnosis and treatment. As oncology science evolves with new discoveries and therapeutic models, the fight against cancer demands
Good evening, ma'am. Could we start with the session, ma'am? Nitya, ma'am?
Yeah, I think we can start. I think we have all the faculty on board.
Yes.
I think we can start. Okay.
Ms. Megha, I'll request you to take forward.
Sure, Roshni. Thank you. Good evening, everyone. A very warm welcome to everyone for today's IAIO case-based discussion on prostate cancer. We're delighted to have you all with us today. To begin with the session, it is my privilege to welcome Dr. S. Nitya, medical oncologist, who will be setting the context and providing an introduction to our discussion. Over to you, Dr. Nitya.
Thank you, IAIO, for this wonderful platform where we could gather and discuss about various malignancies in a case-based approach. So I think this is the third in the series. We already had breast cancer and lung. So I welcome all our delegates and all people who are watching us on the webinar. And I hope that this session is going to be very useful. So today we will be talking about metastatic prostate cancer. We know that prostate cancer is increasing over the times, and it has become one of the most common cancers in males in over the world, especially in the developed nations. So managing prostate cancer has been a challenge because there are very limited options when the disease becomes metastatic, and many of our patients are unable to actually take the full course of treatment or the right course of treatment. And we find that in most patients, a multidisciplinary approach is missing in prostate cancer, especially when they become metastatic. So many of these patients land up taking what their primary consultant advises them to. So it is very important that we go ahead and discuss the right approach to such patients so that we can go ahead and give them the best of what the guidelines have to offer. So today we have with us our esteemed panel, and we have Dr. Satish Kumar, who's a consultant medical oncologist in VS Hospitals. He'll be talking about how to sequence the therapy in metastatic prostate cancer. We have Dr. Lal. We have Ms. Pavitra Hariprasad. She's a molecular genetist. Dr. Lal is a medical oncologist in Cuttack. And we have, he's assistant professor at Utkal University, Acharya Hariyar Postgraduate Institute of Cancer. Welcome, sir. Ms. Pavitra Hariprasad, she's a molecular geneticist by profession, and she'll be talking to us about the molecular pathways involved in prostate cancer and how significant it is in prostate cancer. We have Dr. Sumati Sundaraya. She is head of Department of Nuclear Medicine at Mayotte Hospitals, Chennai. Welcome, ma'am. It's a pleasure to have you on board and to advise us on how important theranostics is important in metastatic prostate cancer today. And we have Dr. Neelam Singh presenting our case today. So welcome to all the faculty. I request Dr. Satish to go on and do his presentation. And after that, we will go ahead with the case presentation and the discussions. I request all the participants who are watching the webinar to put in their comments and to put in their questions so that we can put it forward to the faculty at the end of the session. Thank you, and over to you, Dr. Satish.
Yes, ma'am. Thank you. I thank IAIO for this opportunity and the program director, Dr. Nithya, ma'am, for giving me this opportunity. So let me share my slides. Are my slides visible, right?
Yes, doctor, please go ahead.
Okay. So to the topic in proper, this is a metastatic castrate CRPC sequencing. And we all know that what is the definition of castrate-resistant prostate cancer? The progression of disease by PSA or a radiographic progression despite ADTA with adequately suppressed testosterone, that is less than 50 nanogram per deciliter. So this is a proper definition. Sorry. Yes. So again, we know there are two pathways, the ligand-dependent and ligand-independent pathways. Pertaining to the metastatic castrate-resistant pathway, the ligand-independent pathway takes over, and it may be due to the AR receptor mutation or the AR splice variant or the signal cross-talking between the various mRNAs or upregulation of the co-activator and the downregulation of co-repressor. This is a classical alteration seen in a CRPC cell. And again, in the independent pathway, there may be various mutations like the loss of PTEN, which leads to BCL2 overexpression, which bypasses the androgen receptors and which takes over the prostate cancer cell. And again, if there is a neuroendocrine transformation and the neuropeptides can take over the prostate cancer growth independent of any androgen dependency. These are some of the pathways where a prostate cancer cell can be resistant to the androgen stimulation. And these are some of the prognostic factors, various factors influencing the survival in CRPC. Certain trials have seen that the best OS was with the lymph node only mets rather than the visceral mets. Again, we know the PSA doubling time, which is an important prognostic factor for time to metastasis and the OS. And the other prognostic factors, poor prognostic factors were poor PS, high LDH, increasing PSA, increasing serum alkaline phosphatase, low albumin, and hemoglobin. So again, pattern of disease spread also has a major impact. In case patients with liver metastasis have a more aggressive disease biology and a shorter survival when observed with the ARPIs and chemotherapy. Among other visceral mets, lung mets have a slightly more favorable prognosis. In patients with liver metastasis, with a significant high volume liver metastasis, we generally prefer DOSI or cabazitaxel rather than ARPI due to their poor biology. And what are the recent evolving problems at the present scenario? ARPIs, we know, are now a standard of care for both metastatic hormone-sensitive prostate cancer and CRPC, non-metastatic CRPC. So therapies previously now reserved for the metastatic CRPC have been expanded to the earlier prostate cancer stages, as mentioned before. So switching to an second ARPA, again after disease progression on a first line, ARPA has also been of a bit limited efficacy. So as the NCCN guidelines at present states, there is a new inclusion that is PARP inhibitors along with the ARPA combinations had come in a big way in the upfront setting. We will say it later. So these are the current guidelines from the NCCN with both various category 1 and category 2B recommendations. So I don't want to go much of the trials of the older stats. So we know the frontline metastatic CRPC various trials, the TAX 327, which uses docetaxel, and the impact trial, where the superiority was used as a control. I have not any personal experience with that. And the abiraterone prednisolone in the COAA 302 trial and the Prevail trial, these are all the pre-docetaxel options. And in the post-docetaxel option, we have the TROPIC trial, that is the cabazitaxel post-docetaxel progression, and ABI after docetaxel in the 301, and the AFFIRM trial, the enzalutamide post-docetaxel. And radium 223, the ALIMSA trial, where patients who were not able to tolerate those taxanes and one symptomatic only bone mets have been included in those trials with an survival benefit of around 3.6 months. The remaining trials is a profound and vision we will discuss in detail. So almost all these trials have a OS benefit on a range of around 3 to 4 months. So this is the new PARP inhibitor, which was included at first in the management of metastatic castrate-resistant prostate cancer, namely the olaparib. So the qualifier was the HRR mutation in the tumor tissue. It was basically divided into a two cohort. Cohort A, where BRCA1 and 2 or ATM mutations are present, and the cohort B has other HRR mutated genes. So again, there was a 2:1 randomization with olaparib 300 milligram BD and the physician choice in both the arms. So optional olaparib at BACR progression. So the primary endpoint was radiological progression-free survival, and the key secondary endpoints were objective response rate and overall survival and time to pain progression. So you can see that this was actually post ARPA and a docetaxel setting. So almost all subgroups, whether previous taxanes were used or not, and whether the patient has one bone-only mets or a visceral mets, whatever 0 to 2 ECOG status, and age also randomized based on less than 65 and more than 65, and in different populations, all had a better benefit in PFS. So again, when compared to coming to the OS data is currently a bit immature. There was also a crossing over of almost 80% between the olaparib and the physician's choice, but still they had a minimum amount of OS in all the cohorts, both the cohort A and the cohort B, with the hazard ratios of 0.57 and 0.61 in the prior taxane arm and 0.84 and 87 in the taxane naive arm. So till recently, this was the general notion. In case of a low volume metastatic disease, either we use abiraterone at first. If at all there is no poor prognostic factors, then the sequencing would be the second ARPA enzalutamide, though the PFS will be less when one ARPA is followed by the other. Then if at all then progressing, then we go for a docetaxel, then cabasi post-dosi, and again the radioligand therapy and the PARP inhibitors, which we saw based on the profound trial. If there is poor prognostic factors, when directly go to a taxane-based therapy. If progression on taxane, then enzalutamide and other similar to the favorable subsets. If at all there is a high volume, then upfront docetaxel therapy. If there is no poor prognostic factors, we go for abiraterone. And after abiraterone, whether the progression is less than 4 months or more than 4 months. If it is less than 4 months, we go switch over to a taxane, which is cabazitaxel. If it is more than 4 months, then probably we'll go with an enzalutamide. If at all no prognostic, poor prognostic factors, then directly we'll go for a cabazitaxel and followed by enza or lutetium therapy or a PARP inhibitor after exposure to a taxane or a ARPA. So we know that these are the things which we have followed previously. Is my screen visible? Sorry.
Yes, sir. Yes, it is visible.
Just give me a minute. Sorry, I couldn't see my screen. Yes. Sorry. So, what next? What is the role of PARP inhibitors in metastatic CRPC upfront? Approximately 11% of patients with metastatic prostate cancer may harbor a germline mutation in the DNA repair genes. So, all guidelines, including the NCCN, recommend both germline and somatic tumor testing for patients with metastatic PC at diagnosis. So, what are the tests do we do? This is selected HRR genes, all the MSI genes, and the BRCA2, BRCA1, ATM1, PALB2, CHEK2, and MSI and NTRK. Sorry for the break again. Yeah. Yes. So these are the germline testing done for metastatic prostate cancer. So again, one more important thing is what is the evidence of PARP sensitivity. So not all the genes are sensitive to PARP inhibitors. We do have a very high sensitivity for BRCA2 mutations and only PALB2 mutations followed by BRCA1. ATM check 2 has a marginal or a nil response with PARP inhibitors. So, and BRIP1 has a very minimal sensitivity. So, the importance of slide is not all the HRR genes are sensitive to PARP, that we have to take into consideration. So, mostly BRCA2 and the PALB2 and CDK12 are more sensitive with PARP inhibitors. So, what is the rationale for combining PARP inhibitors with an ARPA upfront? Because the ARPAs induce a phenotype resembling HRR deficiency, and the suppressed ARR function causes an upregulation of PARP. So, basically, ARPAs prime tumor cells for PARP inhibition. This is the role of PARP inhibition. So, the second thing is PARP augments AR sensitivity, and the PARP inhibitors may attenuate resistance to ARPAs. So, PARP inhibitors extend the benefits of ARPAs. So, they both are mutually synergistic. This is the major rationale behind use of both these types. So, now we are going to see all these phase 3 trials, namely the PROPEL, MAGNO, and the TELAPRO trial. Coming to the PROPEL trial, which is a randomized phase 3 trial, it is used in the first line setting with docetaxel allowed at the sensitive stage. No prior abiraterone was allowed. Other NHAs allowed, but the duration should be more than 12 months. An ongoing ADT should be there. So the randomization was a 1:1 with olaparib 300 milligram along with abiraterone 1000 milligram versus placebo along with abiraterone. Primary endpoint was the radiological PFS, and the key secondary endpoint was overall survival. So at the end of the analysis, the primary endpoint, the radiological PFS, had a very good significant separation of curves with almost at the 12-month and the 24-month rates with a hazard ratio of 0.66. Almost there was a 8 to 9 months of benefit when compared with the abiraterone alone with the combination. And again, at the final OS pre-specified analysis, there was a delta of around 7.4 months benefit when compared to the abiraterone alone. So this is one thing. So they have again analyzed OS in both the HRR mutated and non-HRR mutated subgroups. And again, in the HRR mutated subgroups, the magnitude of benefit was bit high when compared to the non-HRR mutated subgroups, with the hazard ratios in mutated subgroups of 0.66 and in the non-mutated subgroups of 0.89. So coming to the next trial, namely the niraparib, the magnitude trial. Here, they initially randomized patients based on the HRR mutations into two subsets. Again, this was in the first line setting, and abiraterone was allowed more than 4 months and with a good performance status. So 1:1 randomization, and the primary endpoint was radiological progression-free survival. Secondary endpoints was time to cytotoxic therapy, time to symptomatic progression, and the OS. So first analysis was with the BRCA mutated 1 and 2 namely, and the primary endpoint can see that the risk of progression or death has been reduced by 47% with the combination when compared to the single abiraterone, both in the central review and the investigator assessed the radiological PFS with good hazard ratios of 0.53 and 0.5 with a median follow-up of 6.7 months. Again, all this comparison has been done in the HRR subgroup, mutated subgroups. Again, there was a significant reduction of progression and death by 27% with a median follow-up of 18.6 months. The final analysis at the secondary endpoint of OS favored the niraparib and the abiraterone group with a hazard ratio of 0.6. You can see that there was the magnitude was less, but there was a 2 to 3 months of benefit in the OS with the magnitude trial. So finally, at the last part, the TELAPO 2 trial, which is used in the first line with a good performance status and an ongoing androgen deprivation therapy. It was a 1:1 randomization with talazoparib plus enzalutamide versus placebo plus enzalutamide. And again, the primary endpoint was a PFS radiological and the secondary endpoint was OS. So at the primary analysis and the updated analysis, which was done in 2024, the radiological PFS was very much significant in the updated analysis with almost a 13.6 months of improvement in the Tala-Enza group when compared to the Enza alone group. Again, the final overall survival analysis when compared to both the subgroups, the Tala-Enza group had a 20% reduction in risk of death and more than 8 months of improvement in median OS. You can see 45.8 months versus 37 months in the Tala-Enza group with a hazard ratio of 0.796. So again, overall survival was compared in the subgroups with no alterations by both the CT tumor DNA and the tumor tissue. CT tumor DNA is also used for all this mutation analysis, and based on various trials, they have a very comparable reproducibility when compared to the tissue mutation analysis. So all the trials have used also included the ctDNA profile also. So again here in both the BRCA, non-BRCA alterated subsets and the HRR negative subsets, there was 11.3 month improvement in the non-BRCA alterated and no HRR alterated subsets. It was around 9.2 months of improvement with the combination. So the final overall survival analysis with any HRR gene related alterations in the intent to treat population was significant with a good hazard ratio of 0.6, and it was quite significant when compared to both the arms. So this was one recent addition which was presented in the ASCO. The piece 3 design similar to the piece 1 we have heard in the metastatic castrate sensitive. So this was in the patients with metastatic castrate resistant prostate cancer and bone metastasis. Both asymptomatic and mildly symptomatic patients were included. There should be no prior enzalutamide or a radium used as in the ALIMSA trial. So as we know, the radiation nucleotide 223 will be used in a 4-weekly manner for 6 cycles along with enzalutamide 160 milligram, and it is randomized and compared to enzalutamide alone. The primary endpoint was radiological PFS and key endpoints were safety, overall survival and other things. So when patient in a castrate resistant setting and bone only meds, the ENZA combined with the radionuclide 223 has a good PFS benefit with a hazard ratio of 0.6 as per the Phase 3 trial. Again, they have a better OS benefit also with 0.69 of the similar hazard ratios with almost a 7 months benefit in overall survival. So next, coming to the radioligand therapy, which is the Phase 3 Vision trial, which is the landmark trial here when compared to the radiotherapy. So patients with a PSMA positive disease. So who is PSMA positive? Any patients who has a PSMA positive metastatic CRPC defined as more than one PSMA positive metastatic lesion with the uptake of more than liver and no PSMA lesions in bone with soft tissue component more than 1 centimeter, lymph nodes more than or equal to 2.5 centimeter, or a solid organ more than 1 centimeter is considered as a PSMA positive disease, and such patients are randomized. This vision trial is done after exposure to an ARPA and taxanes. So basically, it's a 6-weekly treatment of 4 to 6 cycles, and it was compared to the standard of care, either switch over or other subsequent taxanes. In the final analysis, we can see there was a very good OS benefit when compared to the standard of care when lutetium PET was used with a hazard ratio of 0.62. And there was a difference of around 4 months of overall survival benefit with lutetium therapy. So then people thought of why not bringing lutetium in prior to the taxane use. So this was the trial, the PSMA-4 trial. So when there is a confirmed progressive metastatic CRPC and more than as PSMA positive disease, which the definition which we have mentioned earlier, and the progression should be with 1 second generation ARPA, and the patient should be taxane naive. These are all the inclusion criteria. So the lutetium therapy will compared against ARP change, either a ABI or an enzalutamide. And at the final analysis, the radiological progression-free survival with the lutetium PET was better with a hazard ratio of 0.4. But there was not much of a benefit, survival benefit, when it was used before the docetaxel. These are the two major differences between the two lutetium therapies which we have used post-dosi and the taxane naive setting. So in taxane naive setting, the OS benefit was bit minimal. So this was again presented in the recent ASCO 25. So this is the ENZA-P schema, wherein metastatic CRPC patients with raising PSA and PSA more than 5 nanogram per ml with no chemotherapy prior to this one, and more than 2 risk features for early enzalutamide failure. So what are the risk factors for early enzalutamide failure? It's the LDH more than upper limit of normal, and the ALP, albumin, low albumin, de novo metastatic disease less than 3 years since initial diagnosis, more than 5 bone metastasis, visceral metastasis, and the PSA doubling time less than 84 days, pain requiring opioids for more than 2 weeks, and prior abiraterone usage. So these are all the risk factors for early treatment failure on enzalutamide. So such patients are randomized to either enzalutamide or enzalutamide along with the lutetium. So these are the early results, interim results, with good hazard ratios of 0.6 for the PFS. And still, in overall survival, though the data is not mature, still it has a good hazard ratio and widened the gaps in the Kaplan-Meier curve. So there are various ARP inhibitor approvals in different US FDA and the EMA. So olaparib or niraparib, along with abiraterone and prednisolone, is approved for adult patients only in a deleterious or a suspected deleterious BRCA mutations. This we would have seen in the NCCN guidelines based on this. The talazoparib combination along with enzalutamide is approved for adult patients only in select HRR groups. But as per the EMA approval, both the olaparib and the talazoparib is approved in regardless of the HRR status. So what next? When choosing between the all these available combinations, multiple factors should be seen based on the cost and the toxicity differences. And pertaining to the data maturity, PROPEL is the only study with almost a good OS benefit with the mature data. All others are maturing. Again, patients with metastatic CRPC developed resistance on a prior ARPA were not represented properly in the PROPEL, Mangalore, or these TALAPRO trials. So the benefit of these combinations when an ARPA has become resistance is still unknown and had to be seen in the follow-up. So recently, the tumor agnostic therapy after the approval of pembrolizumab for all these things, we generally check MSI and deficient MMR or a TMB high mutation, that is more than 10 mutations per base pair, and the incidence is quite uncommon, less than 9%. The data is, there is no prospective data. The data remained limited to respective studies, and again, it is used only after prior ARPA exposure and not in the upfront. So based on various retrospective studies, 54% of patients had a more than 50% PSA decline and 35% had good radiological responses. So it has given a category 2B in the NCCN guidelines. So regarding the bisphosphonates and the denosumab in the castrate-resistant setting, denosumab seems to be superior than zoledronic acid in terms of SRE, but due to the cost effectiveness, we tend to use zoledronic acid. Again, trials have been proven in the way like 2 weekly is non-inferior to 4 weekly. So it's more cost effective. One thing. One important setting is while during treatment, there is a risk of oligo progression. So there will be always a confusion where whether we have to switch the systemic therapy or what next. So for oligo progressive CRPC, metastasis directed therapy holds good. So it improves the PFS and delays the need for a switch systemic therapy. Based on these two phase 2 trials, the ARTO and the TRAP trial, abiraterone, when used along with STP, the PFS benefit was seen in both the trials. So metastasis directed therapy can be used, and on the next progression, the next ARPA can be exposed. So finally, based on the presentation of the patient, if the patient is a metastatic CRPC without prior treatment with an ARPA, then upfront do a germline and a somatic genetic testing. If it is HRR mutated, then whether prior docetaxel is used or not. If used, then you can consider ARPAs along with the doublet ARPA along with the PARP inhibitor in selected patients. And radium-223 is an option, and cabazitaxel if not eligible for or not affordable for a PARP. So if there is no prior docetaxel, then you have all the options you can do. If there is no actionable alterations, and if there was a prior docetaxel usage, then there are options like ARPA, again the same options. No, then you can use an docetaxel, and cabazitaxins can be included this. So if at all this metastatic CRP patients after disease progression on an ARPA, then again the first step would be the germline and the somatic genetic testing. If at all it is HRR, here MSI is also being tested after disease progression on an ARPA and not in the first line setting. So if there is the same thing follows, whether there is a prior docetaxel, then you can consider an olaparib or a rucaparib PARP followed by lutetium. If MSI high or deficient MMR or more than 10 mutation base pairs, then you can consider pembrolizumab as a tumor agnostic therapy, and all options are available. So if there are no actionable alterations, you go for a docetaxel if not used. So if used, then the second line is you can do a PSMA PET, and if it is PSMA positive, then you can consider lutetium as a therapy, which is quite good. And two things where we prefer taxanes is if there are AR-V7 splice variants, then it is resistant to ARPAs and other therapies. So better go for a taxane-based therapy. And if at all neurocrine transdifferentiation or upfront neurocrine prostate cancer, then cabazitaxel, carboplatin, or a docetaxel with the cisplatin combinations. Basically, taxane and platin combinations can be used for a better response. So yes, thank you for listening. Now, yes, ma'am. Thank you. Am I audible?
Yes, sir.
Yeah. So I have finished my presentation, and I let it to the experts for discussion based on case presentation. Any doubts I can clarify now or at the end?
Dear participants, please post your questions in the chat box.
Thank you, Dr. Satish. It was
Yes, ma'am.
excellent, comprehensive coverage of all the evidence-based strategies for castration-resistant prostate cancer today. And as I said before, almost all of us have problems treating this, and with the available options that are available, I think it's important to actually choose how to go about doing it. I think there will be a few questions to come. I will proceed with the next part of the
Yes, ma'am.
program, which is the case presentation by Dr. Neelam Singh.
Yes, ma'am.
Doctor, I think we can just start sharing your slides.
Okay.
If we
Good evening, everyone. Is my screen visible?
Yes, ma'am.
So, good evening, everyone. So today, we are going to have a case discussion on metastatic castrate-resistant prostate cancer. So we heard a amazing lecture from Sir. So we'll discuss one case and also give you an overview and some landmark trials that is there in the metastatic castrate-resistant prostate cancer. So going ahead with the case, so there's a gentleman, 49-year-old gentleman with systemic hypertension as a comorbid illness. He presented with back pain in November 2020. He was diagnosed to have a metastatic acinar adenocarcinoma prostate with a Gleason score of 4+5, that is 9, a grade group 5, a high volume disease. So there were multiple vertebral lesions with pelvic lesion and supraclavicular node, and he also had one peritoneal nodule. So his upfront PSA was 6,549 nanogram per ml with a left distal ureteric lesion. The biopsy was done from the peritoneal nodule, which was positive for prostatic malignancy. He was then subsequently started on tab bicalutamide and goserelin from December 2020. He then proceeded to receive 6 cycles of docetaxel, completed on May 2021. The serum PSA at that point of time was 3.3. So he continued to receive bicalutamide and goserelin for 9 months, that is around till February 2022, and his serum PSA was around 11.8. So compared to December 2021, which was around 8.5. So PSMA PET done in February 2022 showed a disease progression, particularly in the bones, that is vertebra, pelvis, and ribs. He was then started on leuprolide, tab-abiraterone, bicalutamide, and along with that, Visalon was continued from March 2022. In May 2022, again, a serum PSA was done that was increasing. So that was around 120. The mutation analysis was done that was negative for all the targetable mutation. And then subsequently, he was started on the lutetium therapy. So he received 4 cycles of lutetium therapy, and the last dose was in March 2023. So we repeated a PSA in June 2023 that was around 176. He developed right hip pain and back pain subsequently after that. So we repeated a PET scan, a PSMA PET scan in June 2023 that showed increased uptake in the inguinal and pelvic nodes. And then he received a palliative RT to the right hip, receiving around 30 gray, and that he received till July 2023. He was then subsequently treated outside at a hospital at Vizag for 3 months. And then he was started on enzalutamide from July 2023. Then he reported to our institute in Jan 2024, and we did a serum PSA, which was around 1.1 nanogram per ml. And then we decided to continue his injection leuprolide and tab for. His serum testosterone was done in September 2024, which was around 0.17, and the PSA was around 14. So in view of rising PSA levels, so he received 6 cycles of cabazitaxel, and that was continued till December 2024. And he continued to receive injection enzalutamide with leuprolide. He
Ma'am,
had persistent big back. Yes.
Dr. Neelam.
Hello.
Ma'am, is it
Yeah.
possible, can we project the slide from our end? Because the slide is it is not clearly visible, so that is why I'm asking.
Yeah, we can do that. We can do that.
Sure, ma'am. With your permission,
Shall I
we'll proceed
stop
from our
sharing?
end.
Yeah.
Yes, ma'am. Yeah, we'll proceed from our end.
Just 1 second.
Ma'am, is it comfortable now?
Yeah, can we do it full screen? Yeah. Yeah. We can go to the slide number 4, I guess.
Sure, ma'am. I'll do that right away.
Yeah. So we did a serum testosterone in September 2024, which was around 0.17 with a PSA of around 14. So in view of rising PSA levels, we gave him 6 cycles of cabazitaxel till December 2024. And then he continued to receive enzalutamide and leuprolide. He had persistent back pain in the left shoulder and knee pain in May 2025. So we also did a PSMA PET scan at that point, and that showed an increased uptake in the spine lesions, and there were new lesions in the right knee. And he was then started on TAP phosphoterol, and he received palliative RT to spine, knee, and shoulder, that is around 20 gray. And the serum PSA was repeated in July 2025, which is around 339, and he is continued on TAP phosphoterol with leuprolide and injection Zumeta. So next slide, please. So we've already had a discussion on the management of CRPC. So I would also like to give a very small overview on that. So can we please go to the next slide, please? So as we heard from Sir as well, so the definition of metastatic CRPC. So I would not like to repeat that again. So around 73% of all newly diagnosed patients, they have localized disease, and then we give a definitive therapy, and then when there's a rising PSA, then we have to rule out if there's a biochemical recurrence, and then we need to find out if it's a metastatic hormone sensitive prostate cancer, or it is a non-metastatic CRPC or a metastatic CRPC. So as we can see that around 3,25,000 to 6,51 patients, they do have a castrate resistant disease. So we need to identify the patients by seeing the rising PSA despite the castrate levels of testosterone, and at the same time also identifying the metastasis. So next slide, please. So this slide shows that I've highlighted 3 studies that was done in the non-metastatic castrate-resistant prostate cancer. There's Spartan, Prosper, and the Aramis trial that used apalutamide, enzalutamide, and darolutamide, and it's actually showed almost metastasis-free survival of almost 24 months in the Spartan trial. There was around 22 months in the Prosper trial, and there was also a 22 months benefit of metastasis-free survival in the Aramis trial. Next slide, please. So looking at the flow chart, so as we see how from 1981, where we just had one drug that was estramucin, that we had the FDA approved drug for metastatic CRPC, and how from 1981 now that we have so many drug agents that is available with us for the treatment of metastatic CRPC, going ahead from docetaxel to cabazitaxel, enzalutamide, olaparib, and now that we also have data for the lutetium PSMA based therapies, and along with that we also have the data for pembrolizumab, and how we have multiple agents that can be used, and subsequently how we can sequence them to treat the metastatic CRPC prostate cancers. Next slide, please. So there are a few questions that we really need to address before we go ahead and we manage a patient of CRPC. So first thing is the patient functionally castrated? What are the previous therapies that the patient had received? What was the response to the previous therapy? What was the duration of response? What is the current pace of the disease? Is the patient symptomatic? What are the sites and number of metastasis? Is there a risk of pathologic fracture or a cord compression? What are the comorbidities, and is the organ function compromised? And subsequently, when we have a panel discussion, we would also address the subsequent questions as well. So we can go ahead to the next slide, please. So, whether to decide between chemo versus hormone, which should be used as an initial treatment for CRPC. So in view of a potentially high toxicity associated with chemotherapy, so as we discussed in the previous presentation as well, so a sequential hormonal approach is that should be done. And as there is and in cases that there is a relatively limited metastatic disease and who are asymptomatic disease progression, are the set of patients in which we can actually sequence hormone therapy first, and then subsequently we can think about chemotherapy. And obviously, as we discussed in the previous presentation as well, that the patients who have a PSA doubling time of less than 3 months, if it's poorly differentiated, a high Gleason score, a neuroendocrine carcinoma, or severely symptomatic, or if there's an emergency situation like pathologic fracture or compression or a visceral metastasis. So these are the set of patients in which we would consider about giving the chemotherapy first. So can we go to the next slide, please? So whether to continue ADT or not, so there is a modest survival benefit and with the continued testicular suppression, but also that in one study by the Taylor 1993, but again in the SWOG study that it showed no survival benefit, and there was a modest potential benefit, and there's a minimal risk of treatment. So as a general consensus, to maintain all patients, we should maintain all the patients on the LHRH agonist indefinitely, even while on second line, and also that androgen receptor remains active in CRPC, and also that as per the ASCO NCCN guidelines, it does tell that ADT is something that should be continued. Next slide, please. So these are some of the landmark trials as we discussed earlier as well. So some NOV-22 with TAX-327. So these are all the trials that have shown significant overall survival benefit as well, with the use of agents like docetaxel in combination with estramucin, and TROPIC trial that used cabazitaxel, and that also showed around an overall survival of around 15.1 months. Next slide, please. So this is a chart that also shows the same, that how we have how there is an evolution in the treatment of metastatic CRPC, and we also see a phase 3 Prevail trial that showed the benefit with enzalutamide, and as we can see in the flow chart, how with following docetaxel, there are other options that can also be used for the treatment of metastatic CRPC, like abiraterone, Ciplucil and the radium, and followed by enzalutamide. Can we go to the next slide, please? And in this trial, also following ADT, what are the options as we discussed? So now that we also have an option for treating with the PARP inhibitors, that also we'll be subsequently discussing. Next slide, please. So these are some of the approved systemic therapies that we have for the metastatic CRPC, and as we have discussed in the previous presentation as well. So there is enzalutamide, and there are various drugs. So this basically shows all the landmark studies and what was the survival benefit that was used with each particular drug. Next slide, please. So also that we discussed that we also have bone targeting agents like alendronate, denosumab, as we also saw that denosumab is something that has a better benefit compared to the zoledronic acid, and also that denosumab is taken as a category 1 and followed by the zoledronic acid. And this one thing that I would like to highlight upon is obviously that we should be looking at the creatinine clearance. So if a creatinine clearance is something less than 30, so zoledronic acid, that the dose should be adjusted for the impaired renal function. Next slide, please. So also this slide highlights upon what that there is also that we also have approvals for immunotherapy at this point of time for metastatic CRPC. So this slide basically shows upon what is the mechanism of action based on which the in metastatic CRPC that we are able to use the immunotherapy agents. So it shows about the dosing and the how do we administer and the mechanism of action. So it's up to FDA approval for the MSI high and the MMRD, and with the tumor TMB high solid tumors that have progressed on the prior lines of treatment. Next slide, please. Also that is the data for all the PARP inhibitors, but it's also very important to understand that which are the set of patients for which we would like to do the germline testing, and why we should really do this germline testing. So next slide, please. So this slide shows that, as I said, that who are the set of patients who should be tested for this germline testing. So any patient who have a metastatic disease with a regional node positive with very high or high risk localized prostate cancers are the patient in which whom we should always go and do a germline testing, as well as patients who have a family history or who come from the Ashkenazi Jewish ancestry, of there's a previous history of breast cancers. So these are the set of patients where we should do a germline testing, and these also shows, as we also discussed in the previous presentation, which are the set of markers and when should the testing happen and how the testing should be done. So we can go to the next slide, please. So these are also, as we have discussed, so these basically shows a timeline of the PARP inhibitors and the approvals that has been shown in the metastatic CRPC setting. And we also understood what is actually the mechanism of action of how this, the synthetic lethality of how these BRCA inhibitors work. And then also that right now that we have data of combining the PARP inhibitors along with the other drugs as well. So can we go to the next slide, please? So this as we discussed, so this slide basically shows the role of olaparib and the role of rucaparib as monotherapy in metastatic CRPC. So as we can see here, with the use of olaparib, there's almost a median imaging-based progression-free survival of almost nearing 7.4 months and a median OS of around 19.1 months with olaparib, whereas in the Triton 3 study where it showed almost 24 months of overall survival benefit with the addition of rucaparib in this current setting. Next slide, please. So yes, as this also we discussed, so why do we really have co-target this AR signaling and the PARP inhibitors? And as we know that there's a preclinical evidence for the potential synthetic lethality, and the PARP1 basically interacts with the androgen signaling, and the castration-resistant tumor cells, they exhibit increased PARP1 activity, and the PARP inhibition basically synergizes with the AR-targeted therapy. So that is the entire concept why we really co-target the AR signaling and the PARP inhibitor together. So can we go to the next slide? So this also we have discussed, so I would not discuss. So yes, these are the three major trials. As we know, the Propel Magnitude and the TALOPRO-2 trial that has actually showed the benefit of addition of various PARP inhibitors with the abiraterone and the prednisolone, and also that the TALOPRO-2 that has shown the benefit of adding
So I'm sorry to interrupt you, Dr. Neela. I think we've discussed many of this in the previous presentations.
Yes, ma'am. Yeah,
I
ma'am.
think we will just
done. Yeah,
have some time to for question and answer. So we can just skip through slides that have already been discussed. Yeah.
Yeah. We can go to the next slide, ma'am. We can go. Next slide, please. Yeah, so this is the same. We can go to the next slide, please. Yeah, next slide, please. Next slide, please. So these are some of the radioisotopes that we have for the prostate cancer. Next slide, please. So this also we have discussed as the radium-223 that has shown the benefit in metastatic CRPC. Next slide, please. Yeah, so yeah, this is something that we can address in our panel discussion. So why there is a combining advanced prostate cancer therapy? So what are the challenges? So yeah, is the efficacy of the combination established? Are these added tolerability and safety concerns? Is additional monitoring required? Are the optimal biomarkers understood and are they being assessed? Are accessibility issues adequately addressed? Can we go to the next slide? Yeah, so we have discussed this. Next slide. Next slide. Yeah, so these are the two trials that obviously has shown benefit in the lutetium therapy. Next slide. Yeah, next slide, please. Yeah, so this also is basically the NCCN guidelines of 2025. It shows how we should sequence our treatment in the metastatic CRPC setting. Next slide, please. Yeah, so this is basically that I would like to highlight upon. So patients who have a small cell or neuroendocrine prostate cancers, and what is the choice of therapy that we can see in them. So the next slide, please. Next slide, please. Yeah. So yeah, so these are so next slide, please. Yeah, so this is my last slide. So so it is very important that to understand the disease, to understand the burden of disease, and the how do we really have to sequence the treatment, and then looking at the toxicities as well. So this is my last slide. With this, I would like to conclude. Thank you so much, everyone.
Thank you, Dr. Neelam. I think that was very comprehensive. The case study that you put up, the case experience, I think that is something that most of us have seen in our clinical practice. Very similar cases where they go through that phase of a locally advanced or early hormone sensitive prostate cancer. with minimal metastasis, and we try and sequence therapy, and later they become castration resistant. So that is a typical scenario we see in our practice as well. So we have on our panel Dr. Lal Mohan Soy, a medical oncologist, Dr. Sumati, who's a nuclear physician, and Ms. Pavitra, who's a molecular geneticist. So we will, some of the questions Dr. Neelam had put forth, I think we will discuss those also. I have a personal question. So through our experience, I think it is a constant learning experience when it comes to prostate. So I have a query to the medical oncologist here. How safe are these drugs over a period of time? Because most of these drugs are not used for like 2-3 months, like our other chemotherapy regimens, which last for about 4 to 6 cycles and a max of about 6 to 8 months. So we're giving these oral medications for a very long period of time, especially these enzalutamide and apalutamide. How is the toxicity profile? Because I've never been able to get a good quality of life with enzalutamide for most of our patients. The fatigue and the neurological adverse reactions that come are pretty much severe. So I would like to ask the medical oncologist here, Dr. Lal, if you can give your insights into it. So how have you managed the long-term toxicities of these patients who require a very prolonged and protracted course of therapy?
Yes, all the RPs, if we see, they have a definite toxicity due to long-term effect. Like enzalutamide, we have a toxicity of neurocognitive symptom, and some patient may have developed RAS, hypertension. All the symptoms are there. So we have to evaluate from the baseline what are their neurocognitive status, and we take help from our neurologist if the patient have developed. So sometimes we may have to stop the drug for temporary period.
Okay, sir. Dr. Satish, any insights on this? Whether are there any ways to reduce, or have you found a difference, or is there any difference between enzalutamide and apalutamide in that aspect? Can we substitute or replace to reduce the adverse events? Because many of our patients are not able to tolerate enzalutamide to a great extent, because it's one of the category 1 recommendations on NCCN. It is not as safe as docetaxel or abiraterone. So is it good to, is it a good automatic substitution, apalutamide for enzalutamide?
Yes, ma'am. Personally, I haven't used apalutamide as of now, but based on the toxicity profile, yes, the seizure threshold both has a risk of increasing that and other toxicities. But when compared to enzalutamide and apalutamide, yes, it has a bit less seizure threshold provoking toxicity and other whatever you said. Since I have no experience with apalutamide, I can't compare.
Okay. Thank you, sir. And the other thing here is the use of docetaxel. So many of us, personally, I started with docetaxel in high volume disease, and I found it to be a very safe drug with a very manageable and modifiable toxicity. So it is the dose that you give that gives the toxicity. So we go on for about 8 to 10 cycles. My next question will be to Dr. Sumati. How much is enough, or how much is just enough in case these patients require radionuclide therapy in the future? What is the kind of scenario that you see, and what is the kind of advice that you give us to stop with 8 cycles, or to stop with the 6 cycles? Do you find that the bone marrow is insufficient when we go on? Because for docetaxel, the tolerability is excellent. So many of us tend to go on for about 10 cycles for that. So do you find a difference between stopping docetaxel early and then maintaining on something? Because we need a good bone marrow threshold for radionuclide therapy later. So what is your advice on that for us?
Yes, what we typically see in our clinical practice is that when the patients are referred to us for a lutetium PSMA therapy, they've already had multiple cycles of docetaxel, and they have a disease progression on docetaxel when they are referred to us for the next line of treatment. Most of these patients, most of them already have poor bone marrow reserve. So then it becomes a challenge for us in the real world of clinical practice to initiate the therapy. So then we have to selectively identify patients who are in a very good performance status, at least less than or equal to performance score 2, and whose PSMA PET CT shows very good PSMA expression in all the lesions. And they have to be put on a supportive care. So how much is enough is your question. I mean, you can give up to 4 cycles. If they are able to tolerate PSMA therapy, we can increase it to 6 cycles or even further cycles. So, I mean, but most of the patients in our clinical practice are unable to take beyond 2 or 3 cycles. That is the reality. So what I feel is that if these patients are referred to us earlier when they still have a preserved bone marrow reserve, it would be better. Because in our practice, what we have seen is that even with 1 cycle of PSMA therapy, they clinically improve drastically. And that's, I mean, the patients are very happy. After 1 cycle, we have seen that there's improvement in their pain score. The VAS score improves drastically. Some of these patients have even resolution of the pain. They start feeling better. Their performance score improves. So they have a sense of well-being. And radiologically and PSA response has also been favorable, and it's a very well-tolerated therapy. And these cycles are given at intervals of about 6 to 8 weeks. We can even prolong the cycle to about 12 weeks. What challenges we have is that we have not still optimized the dose. So we give a standard dose of, let's say, 7.4 gigabecquerel, which comes to around 200 millicuries. So if we give around 150 to 200 millicuries, if these patients, despite supportive care, are unable to be given further cycles of lutetium therapy, then clinically what we need to do is prolong their intervals of treatment and reduce the dose. But that's exactly where we are actually lacking, and that's a challenge, that how much is the minimum threshold dose to be given to these patients.
Okay, that's really clear, ma'am. So going forward on the same lines, when a few years back, when we started having radionuclide therapy, it was radium alpha emitting. So how has lutetium scored over alpha? I mean, it's alpha versus beta. So how do you think the difference, it made a difference? Because we see patients being referred for lutetium therapy very frequently now. And that has changed the lives of many of these patients who are in severe pain after failure of several lines of therapy. So how do you think the difference is? What is the difference in the toxicity between the two? Because radium was not actually available in many centers. So we had to send it to other centers, to send the patient to other centers to get it done. And the toxicity was extremely high. So what is the difference between the two? We would like to know on that.
Yeah, so first and foremost, radium-223 has never been available in India. And even if you import it as a salvage therapy on a per patient basis, it proves to be extremely expensive for our Indian patients. So to the best of my knowledge, I don't think anybody has really used radium-223 in our country. And radium-223 is an alpha emitter, which is predominantly for treating the bone metastasis. Now we have actinium-225, which is an alpha emitter. And we have our own Indian experience on the use of actinium-225. When patients progress following 4 to 6 cycles of lutetium-177 PSMA therapy, then the next line of radioligand therapy is actinium-labeled PSMA therapy. These patients do very well. In fact, it is still in the early phases of clinical trial and the results are yet to come out. But wherever the results, the interim results have actually shown very good overall survival and progression-free survival as well. In our experience, alpha emitters, which emits a higher energy and higher damage, causes damage to the DNA, has proven to show significant clinical improvement. You could give up to 6 cycles of alpha therapy using actinium-225. The only challenge with actinium is that it invariably causes dryness of mouth. But the other adverse effects such as anemia or thrombocytopenia is relatively less But almost all patients, after a couple of cycles, maybe 2 or 3 cycles, they develop dryness of mouth, and because of which the treatment has to be discontinued. The second radioligand, which is still under initial phase of clinical trials, is the terbium, which is in between, we would say, in terms of the energy delivery to the tumor, in between lutetium and actinium, because it emits high energy Auger electrons. And it is now available in India, and few centers are already using it. So in those patients where we find that despite giving a couple of cycles of lutetium, there is still disease progression, these two radioligands using actinium and terbium are available as second and third line of radioligand therapies.
Okay, ma'am. Thank you so much.
And one more thing is that as compared to radium-223, which is only directed towards bone metastasis, these radioligands that I have said, lutetium, actinium, and terbium, can be directed towards both visceral as well as bone metastasis.
The other question I have is, how do we assess response in such patients? How frequently do we assess response? Because in chemotherapy and with other targeted therapies, it is only PSA. We generally don't do the PSMA or any other imaging unless the patient is severely symptomatic to plan for local therapy. So how do we assess response, and what is the frequency of assessment of response? And does PSA response actually correlate with the disease response per se?
Yes, so we use both PSA as well as the PSMA PET-CT for treatment response evaluation. And how often we do it is that PSA is done at 2 weeks, at 4 weeks, and PSMA PET-CT is done after 2 cycles, at the end of 4 cycles initially, to look at the treatment response. And most of these, in our experience, we have seen stable disease and partial response in about 30%, approximately 30% each. Complete response is never seen, and disease progression in about 20 to 25% of patients.
Okay, thank you so much. And do you recommend combining it with some systemic therapy? And is there any rationale for any other therapies to be combined with the lutetium to enhance its efficacy?
So in our practice, actually, patients who have been on the first line of ARPI, we put the patient on the second line ARPI along with PSMA therapy. So we have not actually seen, I mean, the adverse effects are seen, it is there, but I feel that it has been synergistic in our practice. And in a couple of patients, we've combined PSMA with olaparib as well. And olaparib basically tends to increase the PSMA expression and has a synergistic effect. But this is like we've done only in a couple of patients, so I don't have the long-term data for them right now. But we have not seen, we've seen good response in these patients, and there hasn't been an opportunity for us to stop the treatment because of this, the combination therapy.
Okay, thank you so much. Going in the same line, I would like to put forth a few questions to Ms. Pavitra as well. This is, I think we are looking at the molecular era where almost every tumor has its own molecular signature. And when do you recommend testing? That is the basic idea, because many of us don't do the testing upfront. So what is your recommendation on the testing, and how should it be done? If we have a clear, crisp guideline on what that is, so we can always tell our listeners and our viewers to follow that in future, because many of our patients have very high grade disease. And should we look for the testing upfront and find if there are options, because something that was there in the 5th line may become 1st line in the future. So are we looking at testing earlier? Is that going to be a dictum? So I want your views on what test to do, when to do, and whom to do.
Thank you so much, Dr. Nityama, for that wonderful question. I think I'm audible. Yeah. So the first thing, whom to test. Basically, as the topic today is for metastatic castration-resistant prostate cancer, they fall into the category of testing for germline mutations that are causative of prostate cancer. And apart from this, no matter if it's going to be metastatic or castration resistant, whatever, just a patient with prostate cancer with a strong family history. And by this, I mean first degree relative, second degree relative, who have had cancers like the breast, ovarian cluster of cancers, or the cancers that are coming under the Lynch syndrome variants. So all these patients can be tested for germline variants. By this, I mean testing the blood. And the use of PARP inhibitors are also mostly based on the germline variants, while there aren't much of FDA approved therapy. Yeah? Any disturbance? Okay.
No.
So while for FDA approved therapies for somatic based mutations aren't available as of my knowledge. And then I forgot what else was the question, ma'am. And the other question I found was whom to test apart from the family history. They would be who have had prostate cancer less than 50 years of age. And again, going on to our topic, metastatic castration resistant prostate cancers. Anything else to cover, ma'am?
No, I think that's about. So I think we got to test all of these patients. That's the basic thing. And
Yes.
when it comes to a higher grade lesion where there is less option for treatment, I think most of us go for it. There is another query we have on androgen receptor mutations. So AR mutations render resistance to many of these therapies that are currently available. So could you throw some light on it? I mean, does that come as a part of the regular testing, the HRR panel, or I think we order for it separately? How is that done? The other question also I have is again the liquid biopsy. Many of these patients, when we test, are already pre-treated. So disease becomes very, very heterogeneous at that point in time. There are a lot of resistant clones. There are multiple biological variants by the time the patient goes through about 2-3 lines of ARPI and chemotherapy. So will liquid biopsy help in such patients, or it is just I mean, just just do a germline HRR, or you just want to test the tumor? If you want to test the tumor, then which is the site of tumor that would like to test?
Okay, thank you so much for that question, ma'am. So coming on to our androgen mutated prostate cancers, these genes are usually covered in the HRR and the MMR genes that we have in our multi-gene panels. These gets covered in the germline next generation sequencing platforms. And coming on to our the other question about the CT liquid biopsies. So this we usually do in a metastatic setup when the sample for the biopsy isn't that much available. We use the ctDNA, which is basically the circulating tumor DNA that we obtain from the blood. Or in case of a metastatic prostate cancer, we make sure we get another biopsy that is easily taken, and this is further tested in case of somatic variants. Again, coming on to a point, somatic variants need to be tested only in the metastatic setup, and the previous biopsy are generally not used when we have a metastatic prostate cancer, which was initially a localized disease.
Okay. What is the role of epigenetic changes here? So how do we really test for it, because that's gaining importance now? And is epigenetics important? And in many of these patients who go resistant, and which is the best way to go about and find out? Are there any significant epigenetic alterations in these patients that you know of?
Epigenetic change, yeah. So epigenetic changes basically are going to be there in your tumor samples. So these are usually done in the somatic variants, while we are not testing much of the somatic samples these days, and I'm not quite sure of its role in the current setup.
Okay, thank you so much. So there is something else I want to ask the medical oncologist as well. Dr. Lal, Dr. Satish, Dr. Neelam, and you, what is your experience with cabazitaxel? I mean, that was a drug which was approved when I was an oncology student way back some 15 years ago. So I found the drug to be really very toxic requiring multiple admissions for febrile neutropenia. But that was one drug which really created ripples across prostate cancer management even before the docetaxel era, where it improved the survival to a great extent, and there were not much of drug options available at that point in time. So I would like to know your experience with cabazitaxel and whether it's a preferred regimen, because that is one of the category 1 recommendations for from most guidelines, barring the toxicity. So have you used it in practice, and how do you manage the toxicity from such drugs?
Yes, ma'am, this is Dr. Satish. Yes, ma'am, we have used in quite a few patients, maybe a couple of patients, but whatever you said is correct. But they have a profound neutropenia, going for a profound neutropenia. And again, patients who are old, basically the prostate patients, whenever they have a cardiac issue, then it is quite difficult to use, because there's one thing. The only thing is we have reduced the dose. The approved dose is 25, and there are trials where lesser dose is also effective. So not quite, ma'am. They are not tolerable quite with that. Probably a couple of patients, that too we have given for a few cycles only.
Okay, thank you. Dr. Lal, your experience with cabazitaxel?
Ma'am, though I have not used the cabazitaxel, but cabazitaxel we use usually after progression after docetaxel. So cabazitaxel has a, you can use the cabazitaxel in a lesser dose if it has a side effect. In place of 25 milligram, we can use 20 milligram per meter square. In standard dose, if patient has an aggressive disease, we use the cabazitaxel in the standard dose. And it has a beneficial as compared to docetaxel with respect to it has less peripheral edema and less reaction or allergic reaction as compared to the docetaxel. So it is a preferred drug, but in aggressive variety we can add with carboplatin also, cabazitaxel with carboplatin in when the progress with the cabazitaxel or docetaxel.
Oh, thank you, sir. That was useful. That was very useful. Dr. Neelam, have you used cabazitaxel in your practice?
Yes, ma'am. So we have used cabazitaxel, but yes, not obviously after docetaxel. So basically, obviously, what I know is, ma'am, that if we have used docetaxel and then subsequently using cabazitaxel, we really don't know the benefit of that. But yes, supposedly, if a patient is on, like we kind of, it depends on how we sequence it. But yes, the major challenge with cabazitaxel is the neutropenia. So and also that by the time we use cabazitaxel, the patient is already post multiple lines of treatment. So the tolerance becomes a major issue. So yes, dose reduction is something that we really do, and also that in a resource limited setting where we don't have enough options. So this is something that is like one of the options that can be used for in this setting, ma'am.
Okay, thank you so much. And for all our postgraduates who are watching, mitoxantrone is also a good drug in metastatic prostate cancer. But let me just remind you that it is only for symptom control. There was no survival benefit at all when it was used. So it reduces pain to a great extent. And if there are patients who have severe pain and you're not looking at extending survival, for symptomatic control, mitoxantrone is a very good drug. So that is one thing we can keep in mind. So
Ma'am,
that is about,
can I ask you a question, ma'am? Ma'am, would you sequence, like if a patient has progressed on docetaxel, would you further sequence and give the patient cabazitaxel, or how would you sequence in this setting?
No, that was my initial discussion with Dr. Sumati. So when we in prostate, docetaxel is not 6 cycles; it is around 9. So that was before this was approved, before the lutetium era. So when we give too much of docetaxel, that automatically causes marrow suppression. And many of these patients, when they progress in the bone and they have painful symptomatic bone metastasis, we are not able to optimize the lutetium dose for them. So most of them have a very poor marrow reserve in the form of low, in the form of cytopenias, especially anemia, and they recover poorly from the radionuclide therapy. So that is the major issue with giving cytotoxic chemotherapy as a primary form of therapy in such patients. So sequencing cabazitaxel after docetaxel failure, I think it will be completely shutting down the gate for all of these patients who are prospective candidates for lutetium therapy. So that is one thing that we have to keep in mind. I used it in my initial practice days where docetaxel was not approved yet. Cabazitaxel was approved for castration-resistant phase, but docetaxel did not gain approval at that point in time. This was about 15 years ago. But cabazitaxel is an extremely toxic drug. Patients require admission. It has a very early nadir. Neutropenia comes on within the first 5 to 6 days. If we don't give adequate filgrastim till the nadir is over, and we really don't know how the quality of filgrastim is now. We were in the era of Neupogen, so 1 or 2 doses could do the magic. For I don't know how that translates now into this generation of filgrastim drugs. So if we don't monitor the patient correctly, the patient goes into a severe febrile neutropenia phase, and the counts, when they go below 500, it takes about a week to 10 days to recover, and we might lose the patient by then, because many of them have resistance to most all these antibiotics. Are they don't work against all these resistant bugs. So that is an important thing. So most of us, we have stopped using cabazitaxel in that era. We have docetaxel now, so I think we have to make adequate use of that drug. It is less cytotoxic, but as Dr. Lal has said, the edema is lesser, the reactions are lesser with cabazitaxel, but still docetaxel I feel is a safer drug than cabazitaxel. So I have completely stopped using this drug because there might be a prospective use of radionuclide therapy, which may be much more beneficial and increase the survival compared to cabazitaxel. I hope that answers your question. So my go-to for castration resistance will be docetaxel, because I tend to start docetaxel early in the disease, even while the patient is hormone sensitive. So that definitely increases the survival over a period of time. The overall survival is definitely higher with docetaxel, and with a higher volume of disease, you combine several drugs, total androgen deprivation, I think they do really well. And the more the time to castration, the better the survival is always the dictum. So we try to give our best agents first. Abiraterone, we've always found difficulty in choosing the right brand. I believe that many of these are not working well because the PSA control comes for about 3 to 4 months, and after that it starts picking up again. So abiraterone is not my go-to for the first line drug. If they are safe to go for chemo, I go for chemo first, and then probably maintain them on abiraterone after some time, along with the androgen deprivation. So a basic goal is to continue the hormone sensitive state for a longer period of time, so that the castration resistance comes late. This strategy has worked in many of our patients. Of course, there are some biological molecular tests available to find out. No, we need more biomarkers. Of course, that I have to tell. We need more biomarkers to tell which of these patients might go in for a castration resistance. There are clinical features like the PSA, the volume of disease, the visceral versus the skeletal, or the bone-only mets, and all those things are available. But there is no algorithm or something like that to tell which of these patients will go into castration resistance early and versus late. So till then, we will have to make good use of docetaxel, optimize the dose. Most of our patients cannot take 100 mg per meter squared, which is the recommended dose. So we cap at around 80%, 150, 140, 150 is the max they can tolerate. So we cap at about 75-80% of the dose, and they comfortably take it. It's given with prednisolone. There is a higher risk of the other complications are there with the altered sugars and BP and all that. But when we optimize the dose, I think the quality of life is excellent. The PSA control is not very dramatic, but slowly starts coming down over a period of time. Regarding docetaxel, we stop at 8. That is the maximum, so that we can allow for the marrow to stay on till the patient requires the next round of therapy.
Can I ask you one question, Dr. Nitya?
Yes, ma'am.
Most of the patients who come to us, they have already had a docetaxel re-challenge. So when do you use re-challenge? Your criteria and how many cycles do you give?
Re-challenge is tough, ma'am. So basically, at the moment, abiraterone seems to be a wonderful drug, oral. It's convenient. There is nothing much to talk about the side effects, so most people prefer that. So the docetaxel comes very late in the armamentarium. For many of our patients, once they reach the castration-resistant phase, they are initially challenged with abiraterone and then enzalutamide, and then docetaxel comes late. So it's almost a very late stage where about 3 to 4 cycles, the PSA comes down by 1 or 2, and then people are happy, and then it progresses, and then we send the patient. There are other options even after that. We have phosphestrol, we have estramastin, all those drugs are available. But personally, I've never re-challenged on docetaxel. It works when we have given it in the early stages, where as an adjuvant or a neoadjuvant. Docetaxel is not yet in the armamentarium yet. So in the early stages, when we give and the patient has responded well, we can re-challenge later when the patient becomes castration resistant, but with very minimal effects. So that is not in my, I don't have an experience of re-challenging, but technically I think that's not going to work much when the patient is heavily pretreated. Again, they're not going to be fit for any form of radionuclide therapy later. And I personally believe that their marrow should be fit for some kind of radiotherapy later, so that they get the maximum benefit out of it.
Yeah, very true. Thank you so much. Thank you.
Ma'am, if you can share your experience on combining the PARP inhibitors and the AR signaling inhibitors, and how do you really manage and monitor the toxicities?
Yeah, PARP inhibitors, the major side effect is anemia. So if we are able to tackle the anemia well, I think that really works. Olaparib was 16 tablets when I was a student. Now it's come down to 4. It was an extremely toxic drug, very promising initially as a BRCA inhibitor when I was studying, but we needed 16 tablets for that. So it was never a convenient dosing. And now we have a 600 milligram dose. In experience, for any indication, no patient tolerates 600 milligram in practice. The anemia is so severe. I've seen anemia as low as 3 grams within about 2 to 3 months of starting olaparib. So we cannot start with a dose of 600. We start with a dose of 300. The max we go is up to 450. 600, the moment you start 600, the hemoglobin starts plummeting. So reduction in white blood cell count is not a concern with olaparib. It doesn't really go that bad, but anemia is severe and the quality of life is extremely poor. So that we'll have to balance. Regarding the combination of PARP inhibitors with ARPIs, yes, because they have non-overlapping toxicities, you can give. But how do you manage the other side effects? So olaparib does not have, I give olaparib as an example because that has the least toxicity of all, is what I believe in. So we have to monitor the anemia and blood counts very stringently. If we go below a threshold of almost 9, the quality of life becomes bad. They are not able to take any drug after that. So they get oral mucositis, all the anemia complications start coming. Many of them have a steroid as well. So there are multiple issues coming along with that. A volume overload comes. So when I've combined both, this is what has happened. But the opportunity to combine has not been, that also I have to tell, the opportunity to combine has not been much because we've not found these kind of HRR mutations in many of our patients. Theoretically is around 40%, but we've not seen many of these patients come back with a HRR mutation. In fact, the last 10 to 15 patients that we've done has turned out to be negative. They don't have any mutations at all. So the opportunity has not been much, but in a couple of patients where we combine, the anemia is an issue. That is the only thing we'll have to watch out for. That comes in irrespective of wherever you use the PARP inhibitors. That is going to be the standout drug. The ARPIs practically don't have much except for the, the next generation of drugs. So I think they don't have much of toxicity to monitor apart from the standard monitoring, but olaparib needs to be monitored for anemia.
Thank you, ma'am. A last question that, ma'am, in which line would you go, like, would you consider doing a biomarker testing and where would you place that?
Ideally, when you transit between a hormone-sensitive prostate cancer and a castration-resistant prostate cancer, is all the investigations should be done. That is the threshold. So going futuristic, I think we need biomarker assay at that point in time to find out why the patient became castration-resistant and whether the standards of therapies will work. Over a period of time, we've noticed that the time to castration is the most important predictor of survival. Whatever the textbook says, whatever the risk factors of progression say, the most important thing is to maintain the hormone sensitive state for as long as possible so that we can offer them the benefit of therapies later. Eventually, almost all patients go castration resistant at some point in time, but you prolong it for a larger period of time, I think it really makes a difference. So at this transition point, we will have to go for the genetics. The HRR testing should be done upfront, but biomarker testing to find out if there is any resistant feature there, resistance feature, all that should be done during the transition phase so that we can diverge in our own pathways to find out which pathway will be actually beneficial to target. The main issue here with the prostate cancer is many of these patients, when we test for therapies, they have heterogeneity. They've been exposed to chemo, they've been exposed to various androgen receptor blockers, the ARPIs, all of them are there. So the tumor is highly heterogeneous. There is one group of cells which is still responding to ADT, and that is why we still recommend giving ADT. It's only a category 3 recommendation, but we still recommend continuing ADT for that one simple clone of drugs of cells which continue to be hormone sensitive. So there is one group which is hormone sensitive. There is one group where an immune milieu has formed. There is one group where there is an androgen receptor mutation. So there's a huge heterogeneous population. So that is why I wanted to know whether the liquid biopsy would be helpful or doing a repeat biopsy from the tumor is going to be there. What is the chance of these patients progressing to a neuroendocrine variant? Because that is one ultimate endpoint for many of our well-differentiated adenocarcinomas of other organs for the mechanism of resistance, because the transformation to a neuroendocrine variant becomes very aggressive and it doesn't respond to the standard of care. And mark my words, adding etoposide is not going to be the solution for all of this, as for other neuroendocrine tumors, because it is the biology that is changing. So we need more biomarkers. So my answer will be to do a biomarker testing at that transition point, but please go for the genetic testing right up front. All high-grade tumors, I'm not going to ask for this testing for Gleason 3+3. It's not going. Many of them don't need treatment at all. So for all the high-grade tumors, for all the high risk, high PSAs, high volume disease, please go for HRR testing upfront. And if there are any biomarkers later, I mean, we don't have any solid biomarkers. PDL1 is there. MMR is always there. That is the tissue agnostic marker now. So it's going to be done for everyone. But going forward, I think we should be integrating biomarker testing at that point in time where they transit to a castration-resistant phase.
Thank you so much, ma'am.
So if there are any more questions, any final words from the panelists? Dr. Sumati, I think we'd be happy if you have some words for us. Just a short summary of when to refer patients to you, and which would be the ideal time. So
I think you have yourself summarized it beautifully. Yeah, so early on, if you are giving docetaxel to these patients and you feel that it's really not working, there is disease progression on imaging and the PSA response is not favorable. And I think that should be the time when you should consider 4 to 6 cycles. 6 cycles is your standard dose, isn't it? Yeah. So at the end of 6 cycles, if you feel that you have identified a group of non-responders, very early on, they should be then referred for the next line of lutetium, yes, radioligand therapy. Because our challenge has been that when they come to us, they already have such a poor bone marrow reserve that except providing a good quality of life, we are not able to significantly improve their survival. So as long as they are with us, they are happy because they have symptom relief, they have pain relief, they feel sense of well-being, but we know that the disease is there. So most of these patients have a stable radiological response. And of course, some of them have really very good response. In fact, there is one patient of ours that I want to actually highlight here, who had a locally advanced prostate cancer causing obstructive uropathy, and he had multiple bone metastasis. He was in such a poor performance status, international patient. He came, I don't know how he flew from his country and came to our hospital for treatment, but he was bedridden when he came. CKD patient. In CKD patients, generally, we do not give lutetium radioligand therapies. But we had no other option. He had very high good expression, and we thought he was already on hemodialysis. So let us see what we can do, as a salvage therapy. We took consent, we explained everything to the patient. We gave 1 cycle of PSMA therapy to him. On day 2nd, the guy wanted to show me that he was feeling good. On day 2, he stood up from his bed just to demonstrate that he could he had that improvement. He felt the clinical improvement. We sent him back, and I never thought that he'll come back again for the 2nd cycle. Fortunately, and to my surprise, to my pleasant surprise, he came back. He came back for the 2nd cycle, and the 2nd cycle, he demonstrated that he could walk up and down. That was the first thing he wanted to show me. So he had no pain. During the 2nd visit, he had no pain. And clinically, he had improved significantly. His follow-up PSMA PET showed significant radiological response. All the lesions showed significant decrease in the PSMA expression. The PSA levels dropped drastically. So these are one-off cases. It doesn't happen too often. One-off cases in a patient who we would have just sent him away with just best supportive care. We were able to give him a significant improvement. And I think these are the patients, it motivates us to actually ideally and carefully select such kind of patients where we feel, okay, let's try, let's go that extra mile and try. Let us see if we can give some treatment benefit to some of these patients. So yes, I mean, we have to carefully select patients at the end of the day.
Thank you so much for sharing that, ma'am. Really, it is motivating for us to go forward and believe that clinical trials are actually producing the kind of results that we see in clinical practice every day. So many of us find it very skeptical to see so many survivals when we are not even able to deliver it to all our patients. So it was very nice to hear that, and it keeps us going at the end of the day. Thank you so much, ma'am. Thank you. Dr. Lal, any words for the postgraduate on how do we sequence therapy in a patient of castration-resistant prostate cancer? There are quite a lot of postgraduates here, so I think it will be nice if you could summarize the sequencing in a couple of lines.
Yes, ma'am. If in M1 castration-resistant prostate cancer, if patient has no prior docetaxel, or if patient has no prior novel hormonal therapy, then we will prefer to give abiraterone or docetaxel or enzalutamide. Any of the drugs we can combine, we can go with ADT. Or if patient has had a progression on prior docetaxel and no prior novel hormonal therapy, then we preferred a regimen is the abiraterone or cabazitaxel or enzalutamide. If patient has progression on prior novel hormone therapy and no prior docetaxel, then preferred regimen is the docetaxel or olaparib in BRCA mutation or rucaparib for BRCA mutation. And if patient has progression on prior docetaxel and novel hormonal therapy, then our preferred regimen is cabazitaxel or docetaxel rechalage. So this is my and other after progression we can consider other like you have told the radioligand therapy or lutetium therapy and radium therapy. The things we can consider.
Yes,
So
thank you.
This question.
So I have a request to all the postgraduates watching today. Go back, take a paper, put a flow chart for all these options that sir has actually told now. For M1 disease, no prior exposure to docetaxel, low volume, high volume, based on prior chemotherapy exposure. Just put a flow chart for first line, second line, and third line, and just keep it in your desk for some time and memorize it. I think that's what you'll use in your practice. Whatever you learn in the book is not going to be there in practice. You're going to get a patient when you first sit in your clinic who has already finished like 2-3 lines of therapy, and you'll be thinking of what to do next. So write down all these options, sequence it well, and so that you'll know how to tell your patients later. Ms. Pavitra, any final word on recommendations for genetic testing for our postgraduates? Just a couple of lines.
just my only request, don't forget genetic testing. They are quite important in the coming days, not just for the treatment purposes, but also for the entire family. Cascade testing plays a very important role. So, along with the HRR genes, MMR genes also play an important role when it comes to prostate cancer, especially in the metastatic castration-resistant prostate cancers.
Okay. Thank you so much. Thank you so much to all the panelists today for sparing their time. We had a good discussion. I think it's a very practical problem that we face in our clinical practice. We are almost running out of options every day when we treat such patients. There is a very rare patient where we are fortunate to continue on just abiraterone for 2 or 3 years. Not everyone is very fortunate, so we need to be appraised of all the options that are available. And our panelists did a wonderful job of giving their opinion and experience on all the treatment options available. So if there are no further questions, I think we can wind up. Over to the organizers. Ms. Megawati.
Yes, ma'am. The participants, if you have any kind of questions, you can ask now or put it in the chat box. Okay, ma'am. Thank you, ma'am. Thank you so much for the evening. It was a wonderful session and it was very informative for our postgraduates as well. So thank you for this event and thank you for everything. Thank you. Have a wonderful evening.
Thank you so much to Dr. Satish, Dr. Lal, Dr. Sumati, and Ms. Pavitra. Thank you so much, Dr. Neelam, for the wonderful case presentation. And we are looking forward to our next meeting in a couple of months, the details of which will be announced, and IAIO will get in touch with you regarding that.
Thank you so much, Dr. Nitya, and the
Thank you.
entire organizing team for giving us the opportunity. It was really a pleasure to be a part of this webinar. Thank you.
Thank you so much.
Thank you.
Thank you.
Thank you, doctors. Thank you.
Thank you, Dr. Nitya, and the entire delegates and faculties. Thank you.
Seminar,